Well, it is 8 a.m. and we are going to be kicking off this session of our Dream Speaker. And to introduce our special guest lecturer, we have Dr. Palmer, one of our outstanding residents, who will be doing the introduction, I'm assuming.
Yes. Yeah. All right. Thank you, Dr. Schnapp. Good morning, everyone. I'm Geraldine. I'm one of the second-year internal medicine residents. It's my pleasure to introduce our Grand Rounds Dream speaker, Dr. Mercedes Carnethon, whose presentation is entitled Contemporary Challenges in the Identification, Management, and Association of Obesity with Chronic Disease in the Population. Dr. Carnethon received her bachelor's degree in human biology at Stanford before completing her graduate training in epidemiology at the University of North Carolina at Chapel Hill. Following a postdoctoral research fellowship in cardiovascular epidemiology and prevention at Stanford University School of Medicine, Dr. Carnethon joined the Department of Preventative Medicine at Northwestern University Feinberg School of Medicine in Chicago. At Northwestern, Dr. Carnethon now serves as vice chair in the Department of Preventative Medicine and professor of epidemiology in the Department of Preventive Medicine and professor of pulmonary and critical care in the Department of Medicine. Dr. Carnethon's research focuses broadly on the epidemiology of cardiovascular disease, obesity, diabetes, lung health, and cognitive aging in population subgroups defined by race, ethnicity, geography, socioeconomic status, gender, and sexual orientations, gender identity. Dr. Carnethon's team has examined the role that diet, physical activity, and sleep play on health across the life course. Her research has developed nearly 400 publications supported by funding from the National Institutes of Health and the American Heart Association. Dr. Carnethon's research has been disseminated broadly throughout top-tier medical journals, along with local and national media outlets. Outside of her scientific research, Dr. Carnethon is an extraordinary mentor in postdoctoral training and faculty development, having received the Faculty Mentor of the Year Award from the Feinberg School of Medicine, Mentor Award for Best Thesis, and Teaching Excellence Award, amongst numerous others. Additionally, Dr. Carnethon serves on a variety of committees, including the AHA Obesity Committee, the AHA Workplace Wellness Steering Committee, and the AHA Committee on Minorities. Please join me in welcoming Dr. Mercedes Carnethon for today's Grand Rounds presentation.
Thank you so much, Dr. Palmer and Dr. Schnapp, and to your committee that was kind enough to invite me today. I have to say, people often ask, are you nervous before speaking? And I will say the thing that makes me the most nervous is the introduction, because it's usually excessive and overstates what it is that I do. I feel very privileged to be in a position of continuous learning. I learn a lot from the people around me, and I learn a lot when I give these talks. So please have your questions ready to go. I wanted to just put up my disclosures slide. I have no relevant disclosures related to this particular work. And I will not be discussing any off-label or on-label medications. So I'm really pleased to talk about this topic. Often when I'm invited to give talks, I have to make a decision. What will I talk about in a given day? And I've settled on being very excited about discussing obesity, given its high prevalence in our population and its relationship to multiple conditions, which makes it an ideal topic to discuss with different types of audiences, your School of Medicine and Public Health, and then also when I'm speaking to schools of public health, we talk about things from a different perspective. So it's a real pleasure, and I appreciate you inviting me as a lowly epidemiologist to be able to describe a little bit about what we do within our field to try to enumerate the problem, consider strategies for managing obesity, and think about how to disseminate and implement these strategies in the population. So I'll start with a little background, and then I'll cover some of the critical challenges in the field, and then discuss briefly future directions, with ideally leaving about 10 minutes for us to have some question and answer. So obesity is epidemic in the United States and around the world, particularly in high and middle income countries. It contributes to mortality from nearly all of the leading causes of death and is estimated to cost the US healthcare system $173 billion a year. You can see here in the figure, obesity really is the umbrella, and that's because there's a relationship of obesity with very many of these leading causes of death. Direct associations with heart disease, cancer. Having obesity is a notable risk factor for higher mortality in COVID-19 illness, stroke, chronic lower respiratory diseases, Alzheimer's disease, diabetes, nephritis, and other kidney illnesses. So again, obesity is pervasive. And this is just referencing its association with causes of death and does not acknowledge the impact that obesity has on quality of life and on management of many conditions that are not fatal. So we've seen really very unfavorable trends in obesity. This figure here on the left is displaying along the x-axis years and along the y-axis the percent of adults who are overweight or obese. These data are outdated, certainly, as this figure is just demonstrating the patterns and trends through 2013, 2014. If we take this out even further, we continue to see this steady increase, particularly in obesity that I've highlighted in both men and women. The prevalence in 2015, 2016, that nearly 3/4 of the population is overweight or obese. And obesity is touching 40% of the population, or approximately 93.3 million adults. The prevalence of obesity is modified by age and other demographic characteristics. We do see roughly equivalent rates of obesity between men and women, and we see a peak of obesity in men and in the total population in the middle ages, with it falling off somewhat in older adulthood, particularly in the men and in the total population, although among women, rates of obesity tend to remain high in older adulthood. And that has to do with a little bit of what I'll discuss later related to changes in body composition with aging that interfere with our ability to accurately quantify obesity and its impact. We see marked disparities in overweight or obesity. One of the common ways in which we display these data are based on race and ethnicity, understanding that race and ethnicity are proxies for many of the adverse social determinants of health that influence one's access to healthcare, their ability to make and sustain positive changes that would enhance their health and life. And we see here in this figure, we have non-Hispanic whites in the dark blue, non-Hispanic blacks in the light bluish gray, Asian in the green, and Hispanic in the light green. And you can see in the total population that we see higher rates of obesity in Black and Hispanic adults. And those patterns tend to hold in both men and women separately. Whereas we might conclude based on this figure that we don't have a problem of obesity in Asians. This is really a misrepresentation because we recognize the importance of disaggregation of racial and ethnic groups given the great deal of heterogeneity within a racial group. For example, among Asians, we do see high rates of obesity and obesity-related conditions, particularly in Filipinos and Asian Indians, and lower rates among East Asian adults. And these higher rates of obesity shorten life expectancy and contribute to what we see are long-term disparities in chronic diseases and mortality. One of the real challenges that we face is stigma in the population. I'll return to this again later in the discussion, but I think it's critical in our framing of the challenges related to the measurement and the management of overweight and obesity. Stigma and discrimination towards persons with obesity are pervasive in healthcare, education, employment, long-term disparities in earnings, in social interactions. You think about the challenges within travel, physical spaces being not accommodating to individuals who've got larger body mass index, and in the media, where often obese individuals can find themselves as the butt of a joke. And these attitudes interfere with individuals' willingness to seek care. They also influence healthcare providers in ways that may be subconscious in how they are discussing the management of obesity with patients. And population subgroups that are defined by these adverse social determinants of health of lower income and lower education already face discrimination based on their race and ethnicity and can often be blamed for obesity. There's quite a blind spot in empathy for individuals who are facing the disease of obesity. And this is particularly challenging because, again, whereas I'm going to use examples from different disease outcomes, I won't focus very heavily on any single disease outcome. But you can see here that medical complications from obesity are relevant to so many disease systems: pulmonary disease, the liver, gallbladder, its association. When I mentioned the association of obesity with poor quality of life, I think about the influence on individuals with arthritis, causing mobility disability, the inability to even live alone because of falls, fractures, and other challenges, cancer, and coronary heart disease and stroke, which has been really my central disease focus throughout my career. So, some of the challenges in the field, I start first with the challenge that we face in even defining obesity in the population. And as an epidemiologist, that really is one of my roles, is to define and enumerate where the problems are and who has those problems in the population. There are two broad categories that we use to define and measure obesity, and these are anthropometric measures and imaging measures. And if we focus now on the anthropometric measures, they have a lot of strengths in that they are measured using standard tools. One can take their own height measurement at home. Individuals, patients, when they show up to the doctor, they are generally weighed before every visit. This is easy. We have commonly used body mass index as a ratio of weight to height and categorized BMI levels to define underweight, normal weight, overweight, and obese. We also have anthropometric measures of waist circumference that we use to estimate abdominal adiposity, because it is not just the overall presence of overweight and obesity, but how that fat is distributed. And I'll return to the imaging measures a little bit later. So for surveillance purposes, we ask these questions: how do we measure the burden of obesity? Where geographically do we see the highest rates of obesity? And what are the socio-demographic characteristics of those who are obese? If I were there with you in person, I'd ask you to raise your hand and say how many of you have seen these maps that are put out by the Centers for Disease Control and Prevention. And the theme of these maps, and I'll just show a brief snapshot of a few, is that the darker colored areas are where we see the highest burden of obesity. And if we look across time, we see the map continually getting darker and darker. This is 2020. I previously showed 2019. When we look at 2021, we see even more dark colors. And every few years, we see the addition of a brand new dark color because the rates have exceeded even what we anticipated. But as you can see, our southeastern states are particularly burdened with high rates of obesity, reflecting 40 to 45%, 40 to 50% of the population, with some of the highest rates in Kentucky and West Virginia. And right now, so one of the disclosures that I may have mentioned is that I'm actually working on a project with the Centers for Disease Control and Prevention. When they approached our team, they mentioned that they are often asked every year when they release these maps, whether their definitions of obesity apply to everyone. Some of you may have heard that the American Diabetes Association, for example, recommends determining obesity and screening for obesity at lower rates among persons of Asian descent. And that's because of an overall smaller body habitus among persons of Asian descent around the world. And so the question of whether the CDC cut points, which are based on the WHO cut points that I showed on the anthropometric scale, are relevant often comes up. So one of the first activities that we did with the CDC was to conduct a review of reviews to determine whether the lower thresholds are warranted and whether they are observed across the population. Our resulting report is currently in CDC review right now, but the short answer and the hint that you get for joining me on an early morning is that fairly consistently, independent of what the outcome is, be it cancer, cardiovascular disease, or diabetes or mortality, we see an uptick in the outcome of interest at a lower body mass index amongst persons of Asian descent as compared with other race and ethnic groups. What we are unable to determine from this review of reviews is precisely where the threshold should fall for persons of Asian descent. And that's because of the challenges and the heterogeneity amongst persons of Asian descent, in that it may be different for persons from Thailand as compared with persons from Japan. And so we are working on that report. Right now, we are screening 4,000 papers, original research papers, to determine the patterns of association that we see in other race and ethnic groups in relation to the leading causes of death. And then we will review the original literature that established BMI as a measure of obesity to determine how appropriate it is. So this is a year-long project that we're doing to help the CDC be able to better quantify where we face challenges with obesity and who is facing the highest burden of those challenges. So moving now to the imaging measures. These are an important tool that we have. We can use them in research. We rarely really use them in clinical practice, although we can gather this information secondary to other screening tests that have been carried out in clinical practice. And the value of these imaging measures are that they allow for an estimation of body composition, the balance of muscle, adipose tissue, and bone, and they allow for estimates of body fat distribution so that we are able to quantify central versus peripheral obesity. And when we think about body fat composition, we give this simple example, and I recall hearing this when I was a graduate student. There's the apple shape versus the pear shape. And central adiposity, or the apple shape, which is often referred to as android obesity, is associated with higher mortality risks because of a greater proportion of adipokines that are releasing hormones that cause vascular damage than the pear shape. And so it's the sort of funny argument that, a large belly will kill you, but a large bottom won't. The pear shape or gynoid obesity, where more weight is carried below the waist, is associated with a more favorable distribution and presence of adipokines and other inflammatory markers that cause endothelial damage. However, we do have, and whereas we usually would do this via imaging, waist circumference can be a reasonable estimate of abdominal adiposity. But a downside of waist circumference is that it's not measured in standard clinical practice. It isn't something that you're going to see in a medical record and be able to make decisions about. And that's in part because standardization of a waist measurement is very tough. You can measure at the umbilicus. Some protocols have you measuring 2 inches below or 2 inches above. And even then, we get incomplete information because where that fat is stored in the central region also matters. And I'll return to that point in just one moment. So this is a really nice example of two individuals, one who appears to be a Caucasian male and another a male of possibly Indian descent. who both have the same body mass index, which is an anthropometric measure of height to weight. This is something you would see in the EHR. This is something that the NHANES study would quantify when they go about creating an overall measure of the burden of obesity in the population. However, down at the bottom, when you look at the image of the DEXA scan and the quantification of the body fat percentage, the gentleman on the left has a body fat percentage of 9% with a BMI of 22.3. And I would point out that a body mass index of 22.3 falls solidly within the normal weight range, whereas the gentleman on the right has a body mass index of 21%. In general, for men, the recommended body fat percentage is below 10%. So these two men look very similar. I would even argue one looks leaner than the other, but the amount of adiposity that he has conveys a risk that is unknowable using anthropometric tools. And even when I mentioned the value of waist circumference, and there is a great value of waist circumference, what waist circumference doesn't tell us is how that fat within the abdominal region is distributed. We have subcutaneous obesity, where the fat, is lying directly below the skin. And the fat here is represented by the yellow. And this is associated when we have subcutaneous obesity. This is associated with less fatty infiltration of the liver, of the heart, and of the muscles. Individuals with this fat distribution in the abdominal region are more likely to have a normal metabolic profile and the absence of metabolic syndrome characteristics such as insulin resistance, hypertriglyceridemia, and low HDL, and high blood pressure. Contrast that with an individual where the yellow or the fat is packed around the organs, visceral adiposity, which is a very dysfunctional adipose tissue distribution that's associated with fatty infiltration of the liver, of the heart, and of the muscles. These individuals tend to have higher rates of all of the metabolic syndrome criteria, as well as high rates of functional disability. This visceral adipose tissue distribution tends to come more often with aging and is associated with what we refer to as a sarcopenic obesity, where one's weight appears to be normal, but the distribution has become more fatty, and that fat is distributed in an unfavorable manner that influences long-term metabolic and vascular risks and damage. So we certainly know that BMI is an imperfect measure of body composition because it is ignoring the distribution of muscle and bone. It doesn't differentiate between body fat and muscle mass, so it doesn't allow us to estimate body composition. It is even more imperfect at the extremes of age. As I mentioned, aging is associated with the loss of muscle mass relative to fat that conveys sarcopenia. And also, body mass index can be very challenging to interpret among children who fall across different growth trajectories. You're going to have some children who are very tall or have a lot more muscle mass, and so they weigh more. And those BMI percentiles, which is how we manage obesity definitions in children, can look very different. And so in those populations, different techniques and tools are needed if our goal really is to estimate their long-term risks related to adiposity. So in population and clinical studies, we certainly have different options. Given the measurement error that's associated with anthropometric measurements, this can really confound and confuse our messages around the risks of obesity. And so for beginning a research protocol, certainly as a reviewer, former reviewer at the NIH, there's widespread availability of tools that range in price to estimate body fatness. There are DEXA scans, CT scans, even inexpensive technologies. And these are two of the pictures that you see on the right. These are bioimpedance analysis scales that can be done in clinic using more complicated measures, or that can be done at home. And during the pandemic, as we were launching some studies where we needed to better estimate adiposity, I decided to buy a bunch of scales and try them out, BIA scales, to see how reliable they are. And I will certainly say that if you plan to use one of these Amazon grade BIA scales, which can, cost you $50 versus high grade BIA scales that I would use in a clinical study, which I generally pay about $500 to $600 for those, that you may need multiple measures and at the same time of day if you're using the inexpensive scales. So we certainly have more options, and I think that we need to use them, particularly so that we can avoid the errors that we see when we discuss this next challenge of unique obesity phenotypes. And this area of research is really where I've done really a lot of my own scholarly work back when I had a little more time to lead studies and write them up. The obesity paradox was very intriguing to me. And the definition of the obesity paradox is that we see elevated mortality in normal weight adults as compared with those who are overweight or obese. So that essentially the middle of this figure is the nadir of risk for mortality. Now, this depiction figure says the risk of premature morbidity and mortality. And I would argue that the majority of the data are referencing mortality, and I don't see the same pronounced U or J-shaped association when we review morbidity or illness. There was an important meta-analysis that came out in 2013, led by Kathleen Flagel, who for a long time was a researcher with the National Center for Health Statistics and has done a great deal of work on the obesity paradox. And professionally, she has been really attacked for these findings by individuals who didn't want to see or believe the obesity paradox. It was very interesting when this paper came out. It is a meta-analysis based on 89 studies. Some of these studies were conducted by Dr. Flagel herself. Others of us contributed other pieces of research during this process that was included in this meta-analysis. And what the findings demonstrated in fully adjusted models are that as compared with the normal weight population, individuals who were in the overweight range had a lower risk of mortality, of all-cause mortality. And it was only when you reached class 1 obesity and class 2 obesity that we see those rates of mortality start to creep back up. Now, I think an important point about this paper is that we describe an obesity paradox. We don't describe an overweight paradox, maybe because it doesn't have as much of a ring, but I think the details of this, that overweight itself doesn't seem to convey immediate risks for mortality, is important. And one of the adjustments that she performed in this particular paper, and where this obesity paradox is often criticized, is the argument that you see wasting at the end of life that's confusing the issue. So in the final 2 years or during the acute stages of an illness, an individual may start to lose weight, which can suggest that a lighter weight is associated with higher mortality. But with 89 studies, she was able to account for that. In the year prior, we conducted a very similar study to investigate the obesity paradox, particularly among adults with diabetes. And in this particular study, our question was whether adults who are normal weight with diabetes were at higher or lower risk for mortality than those who were overweight or obese. The relevance of this question is that 80 to 85% of individuals who go on to develop diabetes are overweight or obese. So it is uncommon to see diabetes develop in the absence of obesity, but it certainly does happen. To conduct this study, we carried out a meta-regression by pooling together 5 longitudinal cohort studies so that we could generate what we call an inception cohort. So enroll people in our study at the time they developed incident diabetes. And this was particularly important because it is the case that some individuals who, when told by their doctor that they have diabetes, respond by losing weight. And so what we didn't want were to enroll people with long-standing diabetes who may have undertaken a weight loss program. We wanted to get them as close as possible to the time that they were identified with diabetes. And that led us to a cohort of 2,600 adults with incident diabetes and 27,000 person years of follow-up. And we had 449 deaths during this follow-up. And what we observed was that individuals who were normal weight at the time that they developed diabetes had a doubling in the incidence of mortality as individuals who were overweight or obese when they developed diabetes. You can see in this forest plot on the left that has the hazard ratios along the x-axis and the categories that we stratified by on the y-axis, that these patterns of association were similar in males and females. They were similar in non-whites as compared with whites, and they were similar in individuals who were developed diabetes after age 65 as compared with those who were younger. And I think even more importantly, they were similar in our study in individuals who were ever smokers versus never smokers. And this is particularly relevant because smoking is associated with the lower body mass index. About a year or two after our study, the group from the Harvard School of Public Health, led by Deidre Tobias, carried out an analysis in the health professional follow-up study that replicated this, and they had a larger sample size. And they observed that these findings were really the most pronounced in individuals. So they were actually able to better stratify by smoking status. And they found that this paradox that I observed was really only present among those who had ever smoked. So I think the jury is actually out on this one, on whether or not among never smokers, we would still see this pattern of association. So, this led to a number of questions about non-traditional phenotypes. And one of these questions that come up is whether if metabolic risk factors are what's driving mortality rather than obesity, then individuals who are metabolically healthy obese should have lower mortality than those who are obese with risk factors. By contrast, if obesity is driving the mortality, then normal weight with risk factors will have lower mortality than those who are metabolically healthy and obese. And I struggle a lot with this term metabolically healthy obese because obesity itself is a metabolic challenge. So this was a paper carried out in 2013 that was a pooled meta-analysis of a number of studies. And the forest plot is showing, again, the relative risk on the x-axis, and the hazard ratios are represented, relative risks are represented by a dot and 95% confidence intervals. What they observe is that there is a non-significant elevated mortality in those who are metabolically healthy obese as compared with those who are normal weight. You can see here a relative risk of 1.19. That said, although the confidence intervals do straddle 1, they're pretty close. So I would argue that this is a trend towards individuals who are obese, even in the absence of risk factors, potentially having higher mortality. They move forward to restrict this to participants who to studies with greater than 10 years of follow-up. And what they observed was a statistically significant finding. So the point here is that if you have had obesity for 10 years or more, the likelihood of having higher mortality goes up. And an important point methodologically is that this study was carried out measuring obesity at a single point in time and didn't account for what happened later. So these individuals were metabolically healthy obese at the time that they captured this association, but those same individuals could have gone on to develop cardiovascular risk factors over time. And this is something that we observe. I am an investigator in the coronary artery risk development in young adult study. And this is a study of adults who were 18 to 30 when they were initially measured in 1985-86. And we just recently finished the 35-year follow-up. And a few years ago, we did an analysis of the duration and stability of metabolically healthy obesity over time. And what we observed was that here at baseline, this is the proportion of adults who were obese. And actually, this is year 7. So we moved 7 years past the baseline when these individuals were at that point. Gosh, doing math on the fly is always an embarrassing thing for me, but that would be 25 to 37 years old. We see a prevalence of obesity of about less than 10%. Of those who were obese, those who were metabolically healthy, close to 85%. Again, these are 25 to 37-year-olds. They did not have risk factors. When we look over time, and I'll animate all of this in, you'll see a trend. You'll see the proportion of adults with obesity going up with time across 30 years of follow-up. And at the same time, you'll see the proportion of those who are obese without risk factors falling over time. And so that to me makes the argument that metabolically healthy obesity isn't a stable trait, particularly in young and middle-aged adults. If you follow them long enough and have a long enough duration of obesity, you will face a burden of cardiovascular and metabolic risk factors. That leads me to conclude that it's risky to categorize obesity as healthy. I think better definitions of obesity are warranted that could allow for subtyping of obesity that conveys risks in a different manner. Prevention and treatment might change with an understanding of the mechanisms by which obesity leads to cardiovascular disease, and different definitions and thresholds may be warranted to define obesity across demographic characteristics based on age and based on sex. I think the jury is certainly still out on whether we need race-specific definitions, and that's something that we're exploring currently with the CDC. Managing obesity, I think, is a really critical challenge, and this is where I'm really pleased to be speaking with a medical audience because we have a number of challenges, right? Obesity is highly stigmatized, which influences how persons with obesity are treated in society. And I underline this because people-first language is important in much the same way as we have moved away from calling someone a diabetic or a hypertensive. Obesity is a disease as agreed upon by multiple organizations, and individuals first should be described. I think persons with obesity face unfair judgments from healthcare providers in many settings, and they also face constrained resources, which can really interfere with their ability to manage their obesity. It is a complex disease. Obesity is rarely a monogenic disease. It arises from a combination of genetic, behavioral, and environmental factors. And so no single approach will work to prevent obesity or treat it once a person has it. We consider the multiple factors, the biological, the individual health behaviors, the interpersonal and cultural factors, and the environmental factors. And so much attention and work is placed on the individual health behaviors. During the COVID-19 pandemic, when the then Surgeon General Jerome Adams made the comment that as a people, and he was referring to individuals who identify as Black, Hispanic, and other racial and ethnic groups underrepresented, needed to do better to control the cardiovascular risk factors. That's a heavy focus on the individual health behaviors, and he was really skewered in the media for the message that we needed to do better because there are so many factors at the environmental level that constrain our ability as a community to do better. When we think about the health impact pyramid and where we can devote resources, so this triangle depicts multiple levels. The base of the pyramid are interventions that would have the broadest impact on populations, socioeconomic factors, environmental factors, and access. Changing the context can really make a big difference. The arrows depict increasing population impact. So you see that pointing down to the base of the pyramid. But then we see on the right side, increasing individual effort that's needed for counseling and education, for clinical interventions. The top of this pyramid requires the greatest individual effort, but those efforts are really in the context of one's environment. So I turn now attention to one of our most successful therapies, and that's bariatric surgery. Bariatric surgery is an effective approach to address morbid obesity. We have about 10% of the population who are morbidly obese and who are eligible for bariatric surgery based on obesity alone. The recommendations for bariatric surgery are expanded not just to those with class 3 or morbid obesity, but those with obesity with other risk factors. So even more individuals in the population are eligible. This is a seminal trial looking at cardiovascular outcomes. These are survival plots. Along the x-axis are years following bariatric surgery. Along the y-axis are the proportion of patients with a primary composite outcome of atherosclerotic cardiovascular disease, or ASCVD for short. You can see a highly statistically significant effect. Those individuals who underwent surgery had about half the likelihood of having ASCVD, atherosclerotic cardiovascular disease, as compared with those who met the criteria for surgery but didn't undergo surgery. So it seems clear-cut, right? Not only does bariatric surgery decrease the likelihood of the leading cause of death of cardiovascular disease, but it can also reverse diabetes fairly immediately. And the leading cause of death in persons with diabetes is cardiovascular disease, although diabetes is also in our top 10 leading causes of death. But then who gets bariatric surgery? We see marked disparities in who seeks bariatric surgery and in the outcomes following bariatric surgery. Individuals with private insurance, high income, or who identify as white are much more likely to undergo bariatric surgery. And unfortunately, even when individuals who are Black or who are lower income have the privilege of receiving bariatric surgery, the percentage of weight loss is smaller in these populations, which means really that the populations with the greatest needs are the least likely to undergo bariatric surgery. We've seen a real turning point in obesity therapeutics. Every day on the news, I hear something new. I'm very excited and I follow this. And I've followed this ever since the debacle over 15 years ago now with fen-phen. You know, we have tried over time to try to come up with a magic pill to reduce obesity. You can see the diet and health behavior change field has all of their arguments about different diets, and same with the therapeutic field. What is the hot new the hot new diet pill? Is there something simple? But we haven't seen something simple. What we've seen are a series of fits and starts related to the complications, related to access. I had the pleasure of attending an open workshop sponsored by the NIH recently about the management of obesity. We have a rapidly expanding armament of therapies, whereby medications that were developed for other indications, primarily some of the diabetes management medications, they've entered the landscape of options and created significant demand for these therapies. They are described as revolutionary, a miracle, but also, as you can see in this popular article, a menace because of disparities in access to these pharmacotherapies. The side effects are not pleasant. You know, when I read about rectal leakage, I don't know how many people really want to have to take that on unless it's a very significant and serious problem. And really, all drugs have side effects. There's always going to be a balance between the short and long-term risks of obesity and the side effects from the medication. And so where this has landed us is a significant underutilization of obesity pharmacotherapies. Over half of adults actually meet the criteria for obesity pharmacotherapies, but the proportion of adults who are actually receiving those therapies is dramatically lower. And when we ask adults whether they're aware of their eligibility, only 15% are actually familiar with the guidelines for indications for medications. Lack of insurance coverage poses a significant barrier for accessing medication. There are high out-of-pocket costs even when it's prescribed. Trying to get insurance companies and their formularies to add these medications in has been a challenge. They are expensive, and without clear designations of obesity as a disease, some have balked at providing coverage. And so there's a lot going on the policy landscape to try to make this case. Right now, only 7 state Medicaid plans and no Medicare plans are providing coverage for obesity therapies. Again, populations with the greatest needs are the least likely to receive these pharmacotherapies. And when we think about who those people are, I will put up this figure. This is a map of Chicago divided by community areas. This is depicting the age standardized prevalence of obesity, with the darker squares and areas reflecting neighborhood community areas with a greater burden of obesity. Those of you who may be familiar with Chicago know that these dark spaces are where we see higher proportions of Black and Hispanic individuals. If you can read very closely the area where the label Chicago is out near the east, near the lake, that's, for example, where Northwestern University is, and the area that's called the Magnificent Mile, higher income areas. You see much lighter colors there for obesity. When we use the CDC Social Vulnerability Index, which is a conglomeration of a number of factors, including poverty, access to transportation, crowded housing, and income, you see darker levels indicating a higher degree of social vulnerability in the very same communities where we see high rates of overweight or obesity. When we looked within our cohort studies in the Cardia study again, to look at how neighborhood level racial residential segregation is associated with obesity, what we did was we used census-based segregation measures captured over time and categorized into high, medium, and low. And what we observed among women, and I have blue boxes around segregation, higher rates of segregation were associated with higher incidence of obesity. And this is when individuals continue to move to neighborhoods that are more racially segregated. Surprisingly, we don't see these findings in men. And my colleague, Kiari Kershaw, who's been a real leader in this space, has replicated these analyses across multiple studies. And neighborhood level racial residential segregation tends to impact females to a greater extent than it does males. So, the question then comes up of what should we do about this? There was an amazing study years ago that was a natural experiment, a randomized social experiment where women were randomized to receive housing vouchers that required that they either move from poor neighborhoods to neighborhoods with lower poverty rates, or a voucher to move to any neighborhood of their choice. Now, they also happened to collect some physical measurements. And what they observed was that moving from a neighborhood with a high level of poverty to one with a lower level of poverty was associated with modest but statistically significant and potentially important reductions in the prevalence of extreme obesity. This is the BMI greater than or equal to 40. You see a reduction of, you see the prevalence there of 17% as compared with 58% among, those individuals who moved versus the traditional voucher. You can see a significant difference in the prevalence of obesity. And you see markedly lower rates of glycated hemoglobin or hemoglobin A1C, which is a marker of diabetes. So, I guess the challenge here, this may seem clear, but the questions remain. What informs the risk-benefit ratio for one prevention approach over the other? How do we select intervention strategies to prevent or treat obesity that don't widen disparities, but that promote equity? For example, if we did lower the criteria for bariatric surgery, would we still see those same barriers and who is even offered bariatric surgery? So we could do that, but how will it help us promote health equity? And then, resource allocation for preventing and treating obesity is required, but the people who make those decisions may not have a vested interest in redistributing resources in a manner that doesn't serve their community as well. So what are the types of arguments that we make at the population and policy level that resonate with the group who may feel that they're losing resources? I think a number of directions in obesity management are to address and eliminate stigma around obesity as a personal failing, focus attention on the base of the pyramid by changing the environment. We don't need to move people. We need to make neighborhoods better and equip them with the resources so that individuals can better manage their obesity. Disseminate effective interventions for obesity to the populations at greater risks. Make sure that newer pharmacotherapies and surgery are available and are supported. When I consider some of the future directions, I think we need to carefully consider how we define obesity and measure it in the population so that we can allocate resources accordingly. We need collaborations with individuals from the dissemination and implementation space. We know about effective therapies. Where we're struggling is getting them out to the people at the highest need. Policy work is needed to provide access to these therapies and to argue with insurers about what should be covered and how covering some of these therapies will really help persons with obesity manage very expensive chronic conditions. And also we need to scale back, we need to dial back our attention on youth before they fall on this trajectory of weight gain. As we have seen, metabolically healthy overweight is a transitory state. Metabolically healthy overweight turns into metabolically healthy obesity. And then with time, cardiovascular risk factors tend to accumulate. So those are some future directions that I think are really critical for us. And before we turn to questions, I really wanted to acknowledge funders of my research, the NIH, the CDC, American Heart Association, and the American Lung Association, and the colleagues that I'm working with in this space. So thank you very much for your attention, and I'm happy to take any questions.
All right. Thank you, Dr. Carnethon. It was a really stimulating talk, and I think resonates a lot with our clinical practice. One question that I had kind of thought about throughout your discussion is, in those studies that we're looking at, normal weight versus overweight versus obesity, do you feel like based off of the BMI, were we missing some patients that might have that sarcopenic body distribution that you mentioned earlier? And that's kind of why we might be seeing more adverse outcomes in the healthy weight or overweight populations?
Yes, your question suggests that you are working actively in this space. That is precisely where I think the misclassification is coming in. And it is much more extreme in older adults who tend to lose muscle mass with age. We hit an age of fairly peak muscle mass, and it gradually declines over time. And so if you simply rely on a measure of height to weight, these individuals may be classified as normal weight, but they may look like that figure I showed, where you've got two individuals in the normal weight range, one with an adiposity distribution double the recommended levels versus the one who is completely normal. And without imaging, we are going to face this misclassification, and that could as well be why we see higher rates of mortality in these populations. And so when we do this work epidemiologically, it is important to stratify by these demographic characteristics that we know are associated with measurement error based on body mass index.
Thank you.
I guess I can also look in the Q&A in the chat for questions.
Yeah, I can kind of summarize this question that's in there. So they are just bringing up the thought that in the 1940s, it was rarer to see an overweight or obese individual. And are there societal changes that contribute to obesity in our generation and population? They talked about unfulfilling work, glorification of fast food, or fewer needs to be physically active in our daily life. And if you have any thoughts on that,
I certainly do. Yeah. It was interesting. A few years ago, I was giving a talk on trends in overweight or obesity in the population and what was contributing to what we'd seen. Now, in the mid 1980s, we saw a significant uptick in rates of obesity in the population. And sometimes when you see marked changes like this, it's because of a change in the definition. But it was also in part because of societal changes that we've seen over time. And at the risk of fulfilling stereotypes that place the blame and burden on working mothers such as myself, what we have seen over time are an increasing number of women entering the workforce. And as women were entering the workforce, we see less time to prepare healthy home meals. And you think in the 70s and 80s, the convenience factor of TV dinners. Well, that's great. You can just serve your family a healthy TV dinner. Well, the sodium in those TV dinners, the amount of fat and preservatives, that's taking us away from healthy whole foods. As we have created a society where we expect access to healthy fruits and vegetables year round, we're shipping products around the country and we're shipping them with preservatives. We have less of a reliance on healthy foods. We've also seen societal shifts to sedentary employment and occupations where we're sitting all day. Because of safety in communities, we don't send our kids outside to play all afternoon as I did in the 80s. Kids are sitting inside on devices. And so we've seen a number of societal factors that have potentiated obesity, and we have not found a way yet to counteract those to promote healthy lifestyles. You know, we say that our environment itself is what's obesogenic, and we need to find ways to change the environment to make the healthy choice the easy choice.
All right, thank you. Let's see. There's another question. It said, obesity data you shared has many characteristics of a contagious disease. Are any interventions designed for infectious disease? Example, intervene in social influencers being tested in components of obesity prevention.
Oh, and what a wonderful question from my dear colleague. Thank you so much, Dr. Astor. It's good to see you. You know, I am not aware of that. You know, one of the challenges that I might see there is, so there is a movement of, it's the fat acceptance movement. And its goal is to really try to destigmatize overweight or obesity. You know, whenever someone puts something positive out about the ways in which heavier bodies move, the ways in which we do have a diversity of what we expect as far as overweight or obesity, there's a backlash on the other side from people who still want to stigmatize and victim blame. You know, I think about the leadership of a female rapper, Lizzo, who, you know, she's proud to be her. She has quite the anthem of "Accept Me." She wears very few clothes when she performs. And, you know, there's a lot of people for whom Lizzo is a hero because she's a performer, she's a singer, she's talented, she's bright, all the things that she could do. But there's so many hate mongers on the other side saying negative things that it's this constant battle of how do we celebrate and not stigmatize individuals, but also still try to maintain a focus on being healthy at any weight. I think if we can shift the conversation to healthy at any weight, so that even if somebody falls within the overweight range, if they're physically active, if they're eating well, if they're sleeping well, celebrate that, because I think those steps can also really help to reduce the likelihood of the obesity associated complications.
Thank you. Looks like we've got one more question. We'll use this as our last one just because we're running out of time. Could you comment on genetic factors in favor of triglyceride-related injury, PNP LI3, for example, and those that protect, and how they are distributed in relation to racial backgrounds? How do these factors? Oh yeah, go ahead.
Oh, sorry. Yes, I know. I was looking at it too and skimming it live. How these factors play into the general discussion of the need for healthcare and environmental resources. You know, I'm not familiar with that particular gene polymorphism, I assume. The work on genetic factors related to obesity have centered on a few different regions of interest that are associated with obesity. The vast majority of obesity isn't due to a single gene. I do see great potential in using genotyping to identify some of the reasons for obesity, because if they are related to a specific pathway, such as the one you allude to that's referencing the triglyceride pathway, perhaps that changes which therapy we should use in order to manage it. I see a lot of room and space for pharmacogenetics in how we choose treatment strategies for individuals with overweight or obesity, because in response to any type of intervention, be it a lifestyle intervention, be it bariatric surgery or pharmacotherapy, we will always see a distribution of responses. And part of that variability could be due to the underlying genetic variability within the population.
All right. I think that's all the time we have today for questions. Dr. Carnethon, thank you so much for joining us and giving us this very interesting and stimulating Grand Rounds presentation. It was a joy to have you as one of our Grand Rounds Dream speakers, and hopefully we'll be able to get you up to Madison.
Yes,
some other
I'm
time.
sorry I couldn't come. Yes, absolutely. Well, thank you all very much.
All right. Thank you.
Great. Thank you.